First case is a 43-year-old man. He's a delivery driver. He fell off his loading bed. He was found to have bilateral distal radius fractures, right worse than left. For the right, he was closed reduced, put in a sugar tongue splint. For the left, he was provided a removable wrist splint. Next case is an 8-year-old boy who fell. He was found to have a left saltaris 2 distal radius fracture. He was put in a sugar tongue splint. Next case is a 13-year-old boy who fell off his skateboard. He was found to have a left both bone forearm fracture. He was closed reduced and put in a sugar tongue splint. Next case is a 78-year-old female with a past medical history of breast cancer in remission. She fell. She was found to have a left proximal humerus fracture. We acquired traction x-rays to see if the shoulder reduced. She said she was feeling a little bit better after we provided traction. She was given a collar and cuff. She was neurovascularly intact. Next.
It was that last x-ray after the traction? Or was this the
second?
Oh, that's it.
Second x-ray.
So the axillary is.
The axillary was without traction. Sorry.
So I guess you can't tell if it got better on the lateral or the axillary.
Ryan, on the lateral x-ray, just tell us where anterior and posterior are.
So on the axillary?
Yeah.
Should be anterior.
That might be a good one to review. That might be a good one to review with your senior resident.
When in doubt, where there's a lot of space, that's anterior because they're usually laying down when they do this. Right? And where does the humerus go when it's displaced, anteriorly or posteriorly? Where would the shaft go in displacement? Where does the pec bring the shaft? Posteriorly or anteriorly?
Anterior.
And where's the shaft in relation to
anterior.
the head? So the ball looks like it's in the socket, right? So where do you think on the, because there is no lateral, you only got 2 AP views, which are nice. And you got an axillary view. You got the axillary view to make sure the ball's in the socket. And is the ball in the socket?
It looks reduced, yes.
So is the shaft anterior or posterior?
Anterior. Next case is a 62-year-old female who fell. She had a left base of the fifth metatarsal fracture. She was put in a posterior splint. Thank you.
First case is a 9-year-old female. Status was fall from a scooter with a right distal both bone forearm fracture. She was neurovascularly intact, was reduced and placed into a sugar tongue splint. Next patient is a 6-year-old female with a history of cerebral palsy. It's non-ambulatory, nonverbal, presented with right lower extremity pain for an unknown amount of time. Found to have this right distal femur fracture. She was placed into a very well padded side slab splint. This is a 62-year-old male, status post-mechanical fall at work with a right hip intertrochanteric fracture. He was medically optimized and taken the next day for a right hip intramedullary nail.
What do you
This is
think of
a-
your tip? You know what a tip apex distance is?
I do. It was just under 25 on my measurement. This is a 71-year-old female, status post-fall with a right distal radius fracture. She was neurovascularly intact, closed, reduced, and placed into a sugar tongue splint. This is a 63-year-old female, status post-fall with a right distal radius fracture. She was neurovascularly intact, closed, reduced, placed into a sugar tongue splint. This is a 30-year-old female, status post-fall from a scooter with a left non-displaced radial neck fracture. She was made non-weight bearing in a sling with early range of motion exercises. This is a 73-year-old female, status post-pedestrian struck with a left tibial plateau and proximal fibula fracture. Obtained a stress view of the ankle that was negative. CT scan. So she was made non-weight bearing in a bulky knee immobilizer. This is a 32-year-old female with an isolated right posterior mallet fracture, suffered 2 days prior. She was very anxious about it and had a lot of difficulty ambulating, so I put her in a short AO splint. This is a 25-year-old female, status post fall with a left great toe distal phalanx fracture. She was neurovascularly intact and made weight bearing as tolerated in a hard sole shoe.
What kind of analgesia did you use for the wrist fractures that you reduced?
Just a good intra-articular, or not, hematoma block.
Those reductions were nice. Good job.
Good morning. Our first patient is a 63-year-old female.
Maybe you can help me out with the $5. I'm sure I was just released from the hospital.
My friend, I'm late for a call.
Sorry. First patient is a 63-year-old female presenting after a fall. Left index finger metacarpal phalangeal joint dislocation. Closed reduction was attempted. It was unsuccessful. Patient was taken to the operating room for an open reduction.
Which way was it dislocated?
It was a dorsal dislocation. So the volar plate was interposed in preventing the reduction.
And were you able to reduce it closed, you said?
No, we attempted a closed reduction. It was unsuccessful. So the patient was taken for an open reduction in the operating room.
And what approach did you take?
We took a dorsal approach. So we made a dorsal incision over the joint and retracted the extensor tendon and were able to visualize the joint. We attempted to use a freer initially to kind of almost like shoehorn the joint into place, but the volar plate was still blocking the reduction. So we incised the volar plate a little bit.
And where did the volar plate come off, distally or proximally?
It came off proximally. So I believe it was still attached to the proximal phalanx.
Where does it come off when the PIP dislocates?
Distally.
Good.
So Dan, this is a great case, and the key is splitting that volar plate when you go dorsally to reduce it. The other option is obviously to go volarly. And what's the risk of doing a volar approach to get down to the metacarpal phalangeal joint in this location?
Yeah, there's a high risk of neurovascular injury. A lot of times the neurovascular bundle can actually be directly under the skin where you make your incision.
exactly right.
Dan, how did you attempt your closed reduction?
So closed reduction was attempted initially by flexing the wrist to kind of take pressure off of the flexor tendons. And then the ED had, initially attempted to reduce this with traction, which probably made this worse. So when we attempted to reduce it, it was more of a volar translational force that was applied.
Yeah, that's a typical event where the ED tries traction on these and makes it worse.
Next patient is a 21-year-old female, I apologize, presenting after a fall from a bike with this left distal clavicle fracture. Patient was neurovascularly intact, and patient was taken to the operating room for an open reduction and CC ligament reconstruction repair. Yeah, so we made an incision over the distal aspect of the clavicle, and we were prepared to use a hook plate or some other plate fixation for this, but the portion of the distal clavicle that was still attached to the acromion was very small, so we felt we couldn't get any plate fixation or any screw fixation in there. So we just used Merceline suture tape to go around the coracoid, and after we reduced the clavicle, we basically sutured it around there and secured it in place. We afterwards, we arranged the shoulder, and it was stable under fluoro.
How did you reconstruct the ligament, though?
I apologize. It wasn't really a reconstruction. It was more of a repair at that point. So since the distal aspect of the clavicle, sorry.
To the lateral clavicle.
Sorry, Dr. Pushilin, I think you were cutting out. I didn't hear the question.
Yes, with the hook plate and other plates, how are they usually used for this type of fracture? You don't put screws into the lateral piece. What do you do?
Right. So, I mean, it would go, we would make like a small posterior incision in the AC ligaments and put the hook underneath the acromion and have it kind of support everything in the, keep the joint reduced with screws in the clavicle.
And if you use a plate that bridges superiorly, you also attach it to the acromion, right? So what's the downside of those two techniques?
Yeah, so the downside would be, there's a high incidence of, complications and irritation and loss of motion that results in a second surgery to remove the hardware. So with this procedure, there's no need to go in for a second operation to remove any hardware or anything else. There's, not really a risk of impinging on the joint or causing any other joint irritation.
Dan, did you augment with anything? And did you go all the way around the clavicle or through the clavicle with the Merceline?
No, we didn't feel that we needed to augment with anything since it was stable with range of motion, and yeah, we just basically went around the clavicle, and since we felt that there was good bony contact between the two pieces, the two portions of the clavicle, we felt that there would be good bone healing, and eventually the CC ligament would heal. So the one of the CC ligaments, the trapezoid, was still attached to that distal portion of the clavicle. So it was just the colonoid that was, injured or at this time. So we felt that eventually it would heal since we have good bony contact, and the Merceline would provide support in the time being.
Did you see the trapezoid ligament? Because your original films, the displacement, I don't think, maybe some.
It looked like it was still attached intraoperatively.
I would think it's unlikely if it's that much displaced.
Yeah, it was probably more just the AC ligaments were intact, holding that piece close to the acromion.
Next patient is a 60-year-old female presenting after a ground level fall with this left humeral shaft fracture. Patient was neurovascularly intact, radial nerve was intact. Patient was initially placed in a coaptation splint with radial nerve intact afterwards as well. Patient was followed in the office and transitioned to functional bracing and followed for several months. Eventually, at her 6-month follow-up, these radiographs were shown. She still did have some motion, and the concern was for a non-union. So the patient was taken to the operating room for takedown of non-union and open reduction, internal fixation, and bone grafting.
How many months after the injury did you do that? And what risk factors did she have for non-union or delayed union?
Yeah, so this was done about 6 months after the original injury. She did have a history of diabetes, but it was pretty well controlled. I think the major contributing factor for her was motion at the fracture site. She was obese, did have a large body habitus, making it kind of difficult for immobilization. So she probably had pretty significant motion at the fracture site, impeding healing. Intraoperatively, she did have what seemed to be a pseudoarthrosis as well.
So is there any literature that focuses on a physical exam finding that maybe pointed you to the fact that this could have been fixed a little earlier?
Yeah, so in NYU in 2017, they had a study. They had like 84 humeral shaft fractures that they treated non-operatively. About 87% of those healed 6 months after the injury, but they noted that if there was gross motion at the fracture site at 6 weeks after the injury, it was like 82% sensitivity for that it would go on to a non-union. But since I think it was reasonable to give her a chance to heal a little bit further as well, just given that these can take a very long time to heal, and it's about like a 98% union rate overall. Additionally, the patient wanted to also wait a little bit as she was caring for a sick loved one.
98% heal rate based on what? Is that the quoting Sarmiento's study?
Yes.
That those results have not been kind of reproduced essentially. So it's probably a lot lower than that, but still reasonable, but it's not 98.
Dan, how was the radial nerve after the operation, and how would you assess for function of it?
Yeah, so immediately post-op, the patient had to receive the block, so it was kind of difficult to evaluate immediately post-op. But in the office, I would evaluate her for sensation, the dorsal aspect of the hand, and extension at the fingers and at the wrist.
I'm not sure how good her block was because she was intact immediately post-op.
Why do you give people a block when the most important thing after surgery is to determine how that nerve is?
Yeah, I think it helps with postoperative pain, but additionally, we were able to visualize the nerve throughout the whole operation. We had it protected, so we knew that it was not going to be, interposed in the fracture site or in the hardware or anything like that. So, the fact that we had it visualized throughout the whole surgery, if there was a neuropraxia, the protocol would at that point just be observation and, possible EMG at several months afterwards. So, yeah, I guess the question is if immediately post-op, she did have a radial nerve palsy, that wouldn't necessarily be an indication to go take her back to the operating room.
And so since you mentioned the radial nerve, how did you find the radial nerve in a 6-month-old healing fracture?
Yeah, so the radial nerve, it wasn't as difficult to find as we necessarily would have anticipated, but generally it's medial to the long head and lateral heads of the triceps and like 2 centimeters proximal to the deep head. You can also find it about like 10 centimeters proximal to the radial capitellar joint.
So is there a specific named approach you used? Did you go lateral, medial? Did you go down
Yeah,
the middle?
Sorry, yeah, we did a posterior approach. So-
And what did you do? Did you go on the side of the triceps? Did you split the triceps looking for the nerve?
We didn't split the triceps. We were able to like move it laterally and medially to access the posterior aspect of the humerus.
So you went paratricipital. So you went on the
Correct.
side of it. Did you go from distal to proximal and then find any other nerve?
So we tried to go distal to proximal, but then we started encountering some scar tissue. So we ended up going proximal again and finding it there and then tracing it back down distally.
And is the rate of radial nerve injury higher in non-unions or in primary surgery?
It's definitely higher with a non-union. In general, with the posterior approach, it's about like 11% chance of like a radial nerve injury, but it would definitely be higher. I'm not sure the exact number, but
In general, which one are you talking about? Not non-union or any surgery?
I would imagine that they'd be higher in both compared to like a primary surgery in the setting of a case where there's not a non-union. But I would imagine with a prior surgery, it's probably higher than a non-union.
Non-unions, there's up to, any secondary surgery, including non-unions, about 15%. Primary, depending on the approach you use, can be as low as 4% or 1 to 4%.
Thank you.
Good morning, everyone. First, we have a 2-year-old male fell from a swing, sustained his right femur shaft fracture. He was placed in a spica cast in the OR. Yeah, so it's a long spiral fracture, and so I think that it's a risk for shortening, 2-ish centimeters.
Someone talking because we can't hear anybody.
Sorry for everybody online, McPartland here. So Jomar, just tell me a little bit about overgrowth.
It can happen.
Can happen. So what age range does it occur in? Classic description for overgrowth is about age 2 to about age 6. You can expect overgrowth, but younger kids may not get it. Okay. Those kids, in younger kids, unless it's a motor vehicle accident, though, tend not to have a fracture that shortens under 2. How much overgrowth can you expect on average?
To 2 centimeters.
Up to 2, but you can count on 1 usually, and it's a fairly reliable process. Okay, so how much shortening can you accept in a femur fracture?
You don't want more than 2 centimeters.
Yeah, so if you have a 2 centimeter shortening and then it overgrows a centimeter, you don't want to put a 1 centimeter discrepancy, and that kid's going to compensate fine. You want it to do anything. Okay, but more than 2 centimeters, we're thinking about having to do something to equalize their leg lengths. Okay, and every once in a while we come across a fracture that shortens in a cast, and we have to figure out what to do with it. You can take them out of the cast and put them in traction. If you need to for a week or 2, you can put an X-fix on. You can nail it. This is a very small bone to nail. A 2-year-old, that's not going to happen. We're talking more about bigger 5-year-olds. But it's important to know that overgrowth can and does occur. I've actually seen it happen after intramedullary nailing on the side of the fracture, and had to go into an epiphysedesis on the affected leg because it overgrew, even though we'd nailed it, but that's a rare finding.
And the absolute take home point here too is you cannot pull traction on femur fractures that you're going to put in a spica cast. So if it's length unstable, then you can't really do a spica cast. But the worst thing you could possibly do to a kid is pull traction on the leg and put a spica cast on, because they're going to get a complication, a bad complication.
Thank you. Next, we have an 85-year-old female fell from a stool, sustained this left proximal humerus fracture. Was placed in a sling, made non-weight bearing for early range of motion, passive range of motion. Shaft is not very dislocated in this case, but I mean, it's here. Yeah, it's angulated, but not transfer. Next, we have an 87-year-old female. So that's what's ground will fall with this left acetabulum fracture. For this patient, the decision was made for non-operative management. She's made toe touch weight bearing. She was able to tolerate that with very minimal pain. We'll be following her close, her x-rays closely in the office.
Specify that fracture, Joe Moore.
Yeah, so it's a little tough looking straight at it. It's certainly in this age group and true to what we saw here, there's involvement of the anterior column. I think it's an associated fracture, probably an anterior, probably best fits the anterior column.
Can you loop your imaging again on the CT there?
Pardon me?
Loop your imaging again. Just keep it going. Okay.
Yes, sir. So that's what I gave in anterior.
So that's your
transverse.
I agree the posterior column doesn't look involved there.
Not really, but anterior column certainly. Yeah, certainly involved in the quadrant.
You go back to your original X-ray.
That's not a 2-column injury?
No, surprisingly, Tim.
Yeah, so
It looks like it, but on the CAT scan, you guys are seeing on a smaller screen, but in here, I don't have axials to look at, but it looks like the posterior column is completely intact there.
yeah.
But it's a large anterior column fragment and the wall came with it, obviously. And it looks like the hip may be subluxed anteriorly a little bit on the initial film, or at least the appearance of that. And that is, I worry about that hip being stable in the long run, leaving it as it is.
Yeah.
I don't know if Dr. Pushilin has any opinions about it.
It's not going to be stable. It's just going to fall right into that defect. The question is whether she'll, once everything heals, they might just be ambulating on a very arthritic hip. It just depends how much pain she has, and if it goes on to a bad outcome, someone may be able to do a total on her if it warranted. But the amount of impaction she has in that joint, she's going to get a complication down the road, go on to arthritis, because there's no good way of, even if you reduce, which is hard to do, the old impaction in the joint, if you graft it, there's no good technique for stabilizing. Like in a plateau, you can put rafting screws and it'll stabilize, whereas here there's no good way of putting screws behind it. So chances are something will subside down the road, and she'll either have a bad looking x-ray arthritic hip that's not that painful for her to walk on and it just be stiff, or she'll have a bad looking arthritic hip that's painful and may need a total hip.
For maintaining congruity, is there ever a role for, instead of trying to go and reconstruct everything and fix the impaction, but just to stabilize the column because it's a pretty big piece? Would you ever do a perk screw just to stabilize the column?
Well, in this case, it'll be either very difficult, probably impossible, just because it's how displaced it is. You'll pull it out. You wouldn't be able to do it percutaneously because it's just too displaced. You probably don't have the corridors for the percutaneous. You can open and stabilize the columns, and we potentially do that. But if you don't correct the impaction, she's gonna get arthritis. That's one of the big predictors of our post-traumatic arthritis.
Does this person ambulate, or is this person
Yes.
a non-ambulator?
She ambulates.
And unhealthy or healthy?
Relatively healthy.
So there's no surgical solution for this person? Is that what you're saying?
No,
No,
you know,
there's-
certainly.
Sorry, she can be a total, either limited fixation with some kind of approach, and a total would probably be the best answer for her. It'll give her almost immediate weight bearing and fix the problem down the road. It would have to be coordinated potentially. Sometimes you can get, since the posterior column looks intact, there might be enough for maybe a cup cage that you can do for a total instead of fixing it. But that warrants a discussion with her, depending on her comorbidities and her goals and her family and whoever is available.
Thank you. Next, we have a 23-year-old female assessed with a ground fall with the right ankle bimal equivalent fracture. She's close reduced. She'll follow up with her orthopedic surgeon in New York. Next, we have an 82-year-old female assessed with trip downstairs. It's minimally displaced bimal, right ankle bimal fracture. She's placed into a posterior splint. She'll follow up in the office for discussion of possible surgical management.
It's minimally
Next is the-
displaced.
Pardon me.
It looks more than minimally displaced.
Certainly the medial now, but maybe less so the lateral. Next, we have a 37-year-old male assessed with ground fall with this left navicular bulging fracture. It's placed into a posterior splint. It's made non-weight bearing to follow. It's the dorsal talonavicular. Dorsal talonavicular. It's an intertarsal ligament. Thank you, guys.
Morning. First patient is a 75-year-old gentleman who was on his bike and was bumped into by a stopping car. He had this non-displaced left fibular neck fracture. Dedicated left ankle x-rays, including a stress, were performed to rule out a Mason-Neuve injury, and which was negative, and he was placed into a padded knee immobilizer. Weight bearing is tolerated. Next patient is a 4-year-old female who fell from jumping on a bed to the following bed, who had this right non-displaced or minimally displaced type 1 supracondylar fracture. She was neurovascularly intact and placed into a posterior splint. Next patient is a 14-year-old male who fell playing soccer and had this left Salter-Harris 2 distal radius fracture. He was close reduced and placed into a sugar tongue splint. Yeah, I think it's just
Any of our hand colleagues, is that the PC form that we're looking at there? Did that stay?
Yeah, that's pisiform.
That's weird.
just rotated. It looked okay on the.
Where is, what's connected to the pisiform? Anna,
Some of
where does
the
it go? From what to what? What's connected to it? Why is it there? What structures are attached to it?
the TFCC is attached.
In part, yeah. What else?
CU.
Yeah, it's not. Yeah, it's just,
FCU.
it's FCU is
FCU,
the
sorry.
thing that's holding it in its current position. So
Never seen that dissociate, Tim, but it sounds like you have.
yeah, I mean, you won't see it often like that, but you'll see it.
Next patient is a 13-year-old male who fell and sustained this left distal both bone farm fracture. He was also closed, reduced, and placed into a sugar tongue splint.
Morning. First patient's a 32-year-old female, status post MVC, distal third ulna fracture. It's placed in sugar tongue splint. Next is a 12-year-old female, status post fall with a left Salter Harris 2 distal radius fracture. Closed reduced, placed in a sugar tongue splint. Thanks.
Good morning. First patient's an 11-year-old female. Status was fall playing soccer with a right Salter Harris 2 distal radius fracture. Was closed, reduced, and placed into a sugar tongue splint. It's a 52-year-old female who had a fall and sustained this right distal radius fracture dislocation. Was seen in an outside hospital initially where a closed reduction was attempted and was unsuccessful. She then followed up in the office and was taken for a right distal radius ORIF at about 2.5 weeks. Status post her injury.
Todd, that's technically excellent. My question is why do you think the carpus could not be reduced initially?
So there was the volar ligaments were avulsed off the volar aspect of the distal radius, which you can actually see on the x-rays. And so those had to be moved out of the way in order to reduce the carpus. And then at that point, the reduction was not stable. That's why the pins were placed.
So let's say this went undetected. What kind of pattern would the carpus assume over time if it was treated, let's say, non-operatively?
It would go into a probably a VZ deformity.
Why do you say VZ deformity? What typically is torn for a VZ to occur?
The lunate would be flexed and the scaphoid extended.
This gives you a much bigger problem than an intercarpal ligament dissociation.
So the reason I know this is we just wrote something up about it, but if you don't have those volar ligaments attached, the entire carpus can translate ulnarly. And I think that by stabilizing the carpus, especially with the pin, and then getting the ligaments out of there and reducing the fracture, you've prevented that.
Yeah, when you strip those volar carpal ligaments, particularly the short radiolunate ligament, that entire carpus is completely unstable. And I mean, I have a preference for actually repairing that ligament if you can. I don't like operating on both sides of the wrist at the same time if you can help it, but certainly pinning it gives you a better chance than not at all. That's a really, really bad injury.
If you go back to the initial film, the original injury film, you could actually see that volar flexon, which is actually bigger than a volar fleck in this case, that's sitting in the joint. That I think reflects the radiocarpal ligaments. In order to get ulnar translation, you really have to also tear the ulnar carpal ligaments. I'm not sure they were torn in this case based on the mechanism, although ulnar translation can occur. But when you strip all those volar ligaments, even after fixing that fragment, you could have instability. And it was a little loose, which is why that pin is there. But recognizing that there's something in the joint is critical. And Tim is right about most people going volarly. But if you see this and you strip that entire dorsal piece to free it up, you can address the entire volar carpus through the dorsum. after you skeletonize the radius. So you don't have to go volar, and to go volar just to put a couple of stitches doesn't necessarily make sense. If you could get that piece out of there, it's gonna heal. It's in the right spot now. But a lot of people.
Yeah, I mean, if you shotgun the wrist joint open, you can get volar, but you can't always do that. You know, it depends on the kind of the patient. You end up doing an awful lot of stripping to get that position. But you're right.
In order to free that dorsal piece up, you have to do a fair amount of stripping at 3 weeks. So
That's true. Yeah. I don't like these injuries. These are bad. You just hope this wrist gets a bit stiff. You don't want it to be have too much motion.
Did you consider a bridge plate instead of the dorsal plate and pins?
well, the bridge plate typically you keep in for 3 months, and you got to go back and take it out. I'm hoping that at 4 or 5 weeks, I could just take that radiocarpal pin out. I'll have enough healing and just immobilize it for another couple of weeks, and that's the end of it. And hopefully just take it out in the office. So I think a bridge plate's reasonable, but you got to keep that in for at least 3 months.
Yeah, I don't think that's a bad idea, but it's a long time. And, you know, again, I'd rather this wrist be a little stiff. So I think that's not a terrible choice here. But I think what's been done here is perfect. It's just going to need a little time.
Next one's an 85-year-old female, status post-fall with a left LC1 pelvis fracture. Was made protected weight bearing with a walker, placed on DBT prophylaxis. This is a 67-year-old female, status post-fall with a left femoral neck fracture. She was medically optimized and taken for left hip cannulated screws. It's a 95-year-old female, status post-fall, the right hip intertrochanteric fracture and a non-displaced medial malleolus fracture. She was taken for a right hip intramedullary nail. And she was placed into a short AO splint. This is a 78-year-old female, status post-fall with a right ankle trimalleolar fracture dislocation. She was initially closed, reduced, and placed into a short AO splint, and then taken for a right ankle ORIF.
Can you explain why that plate is not further distal on the fibula?
We felt that there was adequate fixation there. The oblique component of that fracture goes up more proximal.
But if you put the plate just a little more distal, you could have gotten 1 or 2 more screws in.
Yeah.
I mean, you used a 6-hole plate. You have an oblique fracture. You have 3 screws proximally. Wouldn't you want to have at least 3 distally?
Yeah, maybe could have gotten 1 more in there.
First one's a 9-year-old male on outstretched hand with left bone form fracture. Closed reduced, placed in sugar tongue splint. Next one's a 5-year-old female. Brother fell on her knee with the right proximal sublunar metaphyseal fracture. This was placed in a long leg bivalve cast.
Just be careful with that much extension. That's a fair amount of extension. So sometimes it get like uncomfortable, you know, and you get phone calls, got to change cast.
The next one's 83-year-old female with vascular dementia, assessed with mechanical fall with a left non-displaced olecranon fracture. Patient was placed in a posterior splint. This one's a 14-year-old male, assessed was blocking a soccer ball with his wrist with the right serratus buccal fracture. Patient was placed in sugar tongue splint. 16-year-old male, status was blow to the knee while playing football with left tibial spine and Volgin fracture. Patient was placed in the immobilizer, follow-up in the office for surgical planning and MRI.
What's the usual mechanism for something like that?
It's usually non-contact twisting injury.
So this one's a little bit unique. You got a direct blow.
Correct.
Is somebody talking? Because I can't hear anything.
Sorry, Sam, it's me again. I'm letting you down, man.
God damn it, Tommy.
You got to be careful about these fractures because sometimes they can hide. If you have a big swollen knee full of blood, you have to think about osteochondral fracture, this being one of them. And you got to look carefully and scrutinize that lateral. If you don't have good films, repeat them.
What'd your exam show on that?
He was too painful really to get like a good pivot shift test, but there's definitely a positive anterior drawer.
So when your MRI shows a tibial avulsion of the ACL, what are you going to recommend?
I'd recommend surgery.
What surgery?
So you can put a screw through.
That's
that
too small for a screw.
piece, or you can
That's way too small. You'll never get a screw in there. You'll break the piece.
ACL reconstruction. You could be treated non-operatively in extension, and that piece may just kind of sit right back into the. What I would do is I would put them in an immobilizer, obviously an extension, again an MRI, and if the piece is where it's supposed to be, then they'll heal nicely in that position. If I don't know. No.
But you have to think about the fact that you can also weave stitches through the spine and the ACL and then bring it down through a tunnel over a post. And so if you have a bony fragment, that's an option. I'm not a sports surgeon, so I would defer to Dr. Gatt, Dr. Harnley, and others who do this.
That procedure is so much easier said than done.
70-year-old female, assessed with some syncopal episode of left inferior pubic rami and pubic root fracture. Patient was midway bearing is tolerated. Your inlet outlet views. 8-year-old male fell off a trampoline with right bone form fracture. Was reduced, placed in sugar tongue splint. Follow-up 1 week. This is a 6-year-old female trip and fall with a right distal radius green stick fracture. Patient was placed in a sugar tongue splint. Next, a 40-year-old female fell down 2 stairs with a right distal radius fracture. Patient was close reduced, placed in sugar tongue splint. Follow-up was close follow-up. A 15-year-old female fell on outstretched hand with a right elbow dislocation, radial head and corner fracture. She actually fell on a haunted hayride. She was reduced at Jersey Shore, placed in a hinge elbow brace, and followed up in the office. It was noted there was a mechanical block to extension, and a CAT scan was obtained, which showed a small intra-articular piece and displaced radial head fracture. She was then taken for a radial head ORF.
Did you find that fragment that was sitting in the joint?
We did.
And was the motion blocked in the operating room before you started the case?
It was.
What was your ligamentous exam like when you were done?
It was stable.
That's surprising and lucky.
So
Why
just,
does-
I'm going to say, just when you look at your middle picture there, tell me about the congruency of the joint. What are we looking at?
So this is the articular surface here, and that looks like it's adequately
The middle picture.
Oh, no, sorry. The joint here is adequately restored here. And then on other views, that screw is actually countersunk.
What about your own humeral joint? I think that's what he's asking.
Doesn't look like there's any posterior sag that would indicate some instability. It's not a perfect lateral, so I can't say per se, but I'm not overly concerned for this being super unstable.
Why was Tim Leddy concerned, and why is Brian Katt concerned? Why is everybody else concerned? What is there a name for this injury? Like, how many structures were injured here? The radial, right? The radial head was injured. The coronoid was injured. Anything else you think injured that it was dislocated? Were any ligaments avulsed?
LUCL could be injured.
So, have all these injuries, and the only thing you fixed was the radial head. It seems intuitively that this would be unstable if you just fixed one item. And why wouldn't you fix other items since you're there?
You can, but since after we fixed the radial head, it was found to be stable. You don't have to. I don't know if you have to fix the little coronoid piece, and then I think if you do fix the coronoid piece, it may confer some extra stability there. So yes.
How did you test stability in the OR?
So you test stability in flexion and extension, and you can do a pivot shift.
It's just surprising to me that there wasn't an associated lateral collateral ligament injury. And, you know, a lot of times you tack that back on your way out. Now your lateral may be in like the patient being completely externally rotated, which is going to take the pressure off it and it'll look better. But if you got that lateral with his shoulder fully internally rotated, it would gap right open. And I think we're seeing a little bit of that gapping on the lateral. That's what I was getting at. So are you sure you didn't tack some ligament down on your way out after you repaired that radial head?
We did. I mean, when we were completely open, the radial head would subluxate out lateral, which is still pretty common, just because you're looking at everything. I mean, we didn't take down our lateral and our collateral ligament completely, and it was not completely torn off, but we did repair everything on the way out, which you kind of have to. Once it was repaired, we felt that it was pretty stable. These x-rays were taken before we did the capsular repair.
That makes sense.
Next was a 16-year-old male, fell on wrist as post ATV accident 6 months ago with a left scaphoid fracture. Wrist range of motion at the time was 30 degrees of flexion and extension. And this was our first visit to console evaluate healing. CT was obtained, which showed a scaphoid waist fracture, non-union, a slight humpback deformity. Due to these reasons, the patient was taken for the right scaphoid non-union repair, RIF.
How did you fix that deformity? How did you repair the humpback deformity?
So we went volar and we put 2K wires in the proximal and distal piece, and we joysticked it into the position we liked it in. We put a K-wire as an anti-rotational wire, and then we put this another K-wire through to put the screw in.
Right, but did you take the humpback deformity out and straighten it out?
Yes.
So how did you keep it jacked open?
We pinned it. We put a K-wire through it. And then you're saying like after we put the screw in?
Well, hopefully before you put the screw in. What is to prevent it from going back into a humpback deformity? When you jack it open, now you have space between the volar cortices. What's in that space?
It was actually like a fibrous union, so we actually had to remove that. So it was open space there that we backfilled with DBM, and some graft, but we kept it open with a K-wire.
Okay, well that you know.
So, I mean, what you're getting at, Dr. Kirschenbaum, is once the way this kind of healed, almost translate it forward. To reduce it, we had to take some of the bone dorsally out because it had kind of healed in a wedged position. So we were prepared to use distal radius cortical cancellous bone graft, but once we translated everything back and got it reduced, there was actually not a very big volar gap, which I was surprised about. So I didn't think we needed structural bone graft.
That's unusual. I mean, I don't think I've ever seen one where you didn't need to wedge something in there, and in some cases structural. You know, DBX and those putties don't do it, and this, you know, I don't like to rely on a screw alone to help hold it, you know, in a reduced or anti-humpback position. I think you need to, as a general rule, hedge your bets and have something in there that's going to have some staying power.
No, I agree. We were prepared to do it. There was no gap volar once we had it in a reduced position. I was pretty surprised. There was actually a little bit of gapping dorsal, but I think it's the way it had started to heal. We almost had to break up more dorsal healing, and it had kind of, like it said on the CAT scan, you can see it's kind of translated forward, and the fracture is at a angle. So I was pretty surprised. I wasn't thinking we weren't going to need bone graft.
You know, I think, Deirdre, if you ever get a CAT scan on him, and I don't know if you will, just to assess healing, I bet you fixed it in that humpback deformity. And it just looking at the position of that screw in there. And hopefully it heals and he's okay. But I think, you know, the point from the other hand attendings is, you know, usually when I've done these, there's a big gap there that needs to be filled in.
The other point is if you have an established non-union, and it looked like there was sclerosis, although we didn't get a good look at it, and you have an established non-union, formal bone graft is indicated. Just repairing it with a screw and all those other items is, I don't think, the standard thing that we do. We usually do some type of a bone graft because it didn't heal the first time, and now you're relying simply on a screw, which is what we rely on for a fracture or someone that doesn't have a straightforward non-union.
There is some literature to support just putting a screw in and even doing it percutaneously for established non-unions, but I would agree that is not the standard of care. I think that's as a general rule. I think you got to.
I think you have to be very careful on what you're establishing as a non-union, and I'm not talking about cystification or, you know, just delay. I'm talking about frank sclerosis. Once you see frank sclerosis on either side, if that's what you see. If you don't have sclerosis, you can do anything you want, it'll work. But if you have sclerosis, I don't know that people are doing that.
Yeah, that's got to be scraped away. And again, that can give you a false sense of where the fracture belongs. You know, when you see you don't have a whole lot of space and it looks like it matches up, that's because those two surfaces have been rubbing together for a long time to make that sclerosis. It looks like it belongs that way, but it doesn't.
Good morning. This patient was a 70-year-old male, SAS post ground level fall with a left subtroch fracture with intertroch extension. He's medically optimized taken to the operating room for a left femur medullary nail.
Did you think about doing anything with that inferior piece? Looks like it's part of the calcar is attached to it, is it not?
It's so definitely, you know, it's part of the calcar is definitely involved there. It's a little bit tough. So, this patient's, we could have maybe tried to put cerclage wire or try to bring it together, but it wouldn't necessarily be, I don't think it would have made a difference structurally for him. The nail is, bearing, his weight, right now, and think it might have made our x-ray better, but not necessarily affected the structure as much. Additionally, he had a very tight thigh, and we making a big incision and trying to grab that piece that's so far displaced would have been dangerous to do. So I think it's probably the best decision just to leave.
What do you mean by tight thigh? And are there ways of doing that that are not so dangerous?
No, so his thighs are very swollen, so you can, we could have kind of made like a incision, and try to manipulate it around. But the worry is that, given he's already swollen, and if you were to manipulate and open it more, it might have been difficult to close the fascia after you were done doing that bigger open procedure.
So,
what do you think it's going to do for healing? You're right. I agree with you. I think structurally you've bypassed that fracture, and that's a perfect construct to do that with. But now you need Olympic osteocytes and osteoblasts to fill your gap there.
Did you do anything else to the nail? How does this mechanism typically work? What's the kind of principle of the nail in the intramedullary canal with these fractures?
So we did not lock the nail. So there's going to be a little bit of compression and sliding.
What is it sliding to?
So it would slide along the lag screw.
Okay, and what are you trying to compress?
So there was like a small non-displaced fracture in the inner choke region, so there might be a little bit of compression on that part of the fracture.
Okay, so what's the bigger fracture that you're worried about? It's probably that big subtroch area.
Yeah.
So sliding here is not helpful to you. It doesn't add you healing, it adds you to displacing the position of your fixation where you have it, where you like it now. This nail doesn't do it as much because of the dual construct, but if you had a different nail with the sliding screw and you didn't lock it, that the neck of the fracture would be keep going until it hits the nail. And if the nail is not tight in the canal distally, it'll start levering. Then you're going to have quite a deformity, assuming it heals. Preserving the biology is a good answer without opening. It'll probably not to let out the hematoma. The whole thing about this thigh being swollen, probably not the issue why you did it, because thighs will close, and if it's that swollen, there's a different concern. These fractures always bleed. They're always swollen, and you can always close. Well, for the most part, you can always close them.
Do that supine or lateral, Dan?
We did supine.
So you didn't open the fracture site, is that correct?
No, we made a small incision and used the cob to help aid in our production, getting a guide wire across, because the proximal piece was a little anterior and will flex as a result.
So you did open the fracture site?
Not completely, but we just made about a couple of centimeter incision just to slide our cob in there on the bone to help manipulate the fracture, and just using a finger to get our reduction past the wire and then the nail.
Is there any?
Have you seen that linear reduction clamp? Have you seen that?
The collinear, yeah. We just think we thought about it, but just given that there was comminution, that piece is so far displaced, we think that was an option.
Is there any indication to bone graft this?
No. They didn't need bone grafting.
How long is it going to take to heal?
I assume it's going to take 3 to 4 to 5 months. This guy personally is bad protoplasm. He's like liver disease. He has diabetes. So for him, it might take longer.
So if you already opened the fracture, what would be the harm of putting bone graft in there? If it's going to take that long to heal and he's got poor protoplasm.
You know, I'll tell you, I would rather go after that medial fragment and pull that in and reestablish the calcar than bone grafting it. You know, I think all your bone is sitting right there.
I mean, it's one thing if you don't open the fracture and you leave everything alone. But if you open it, and this is guy's going to have a tough time healing, I don't know, it just seemed like something should be done in addition. Otherwise, it's a big war here between the hardware and healing. And if it takes 6 months to heal, who knows what's going to happen.
Dan, are you going to let him walk on his leg? And if you're not, when will you?
I would let him weight bear, but he would probably like self-limit the pain, so he wouldn't put all of his weight down.
If your construct fails, how's it going to fail?
If it fails, I feel like it would kind of cut out through the femoral head. But I think that we had good, tip to apex distance, so I think that is likely.
Serge can tell me if I'm wrong, but I think the nail would break at the subtroch region because you're allowing the screws to slide a little bit proximally.
Subtroch or through the screw holes.
All right, that's it.